Hi folks, welcome to Prep Ladder NEET's new version of the videos. This is your medicine educator Dr. Santosh Patil, and in the new edition, we are trying to accommodate the changes in the exam pattern. So when we recorded the first and second editions of the NEET's videos, the exam was primarily focused on a two-part paper, right? So there was a paper A which was derived from general medicine and paper B which was derived from the core super specialty. So when the exam was of 40 marks, right, very high yield topics is what we focused more on. But now that the exam is expanded to cover 150 marks, all coming from internal medicine, some of the chapters which we had neglected or which we had given less weightage also starts becoming more important. So keeping that in mind, we have started replacing the videos, and I have started replacing my respiratory medicine videos. So in today's video module, we will be addressing bronchial asthma. Okay, bronchial asthma is one topic from which not many questions have been asked, or the questions that have been asked are quite predictable. Mostly the questions were about the management of asthma based on the updated GINA guidelines. And that also means that one needs to be updated with the latest GINA guidelines. So right now in 2022, we should be updated with the 2022 GINA guidelines. But even then, there are at least few questions which appeared in the PGIMER and certain central institutes, and also in the very initial edition of NEET, which were focused on the epidemiology and pathophysiology of asthma. Okay, now the epidemiology as well as pathophysiology of asthma is not very clear. Means like there are a lot of gray areas or a lot of debatable topics or lot can be debated on facts and figures. But nonetheless, at least some of these points are testable in the form of MCQs. If they cannot be converted into MCQs, examiner can ask you which of these statements are true or which of these statements are false. At least such questions are possible. So keeping that in mind, we will learn today about the clinical features, epidemiology, pathophysiology, and diagnosis in the part 1 video. I'm creating a separate part 2 video where we will be discussing the management of bronchial asthma. The reason I'm creating a part 2 video separately is because the GINA guidelines are updated almost annually. So we need to keep replacing that video to keep updated with the latest information. But the basics are generally not going to change so much. So probably we can hang on with this video lesson for long. Okay. So let me start with the epidemiology of the bronchial asthma. Now, when we talk about epidemiology, first point we need to address is in terms of age and gender, what are the risk factors, right? So we clearly know that children are more affected than adults. Children are more affected than adults. Okay, so Harrison mentioned that in the Western population or US, around 8.5% of the children are affected with bronchial asthma, and that is 7 odd percentage of adults. So there is slight preponderance for children, right? So that's the first point we need to know. Children are more affected than adults. Now, when it comes to genders, I need to tell you two important points. So when you talk about children, the gender disparity is skewed towards male preponderance, right? So males are more affected than females with a ratio of 2:1. Now, when you talk about adults, now female starts becoming more affected, or there is female preponderance when you talk about adults. So in adults, females are slightly more affected than males with a very minuscule ratio, like around 1.1:1 or 1.2:1, but still females are more affected in adulthood with bronchial asthma in comparison to males, right? Okay, so that is the first epidemiological factor we need to know. With respect to race, it is quite debatable because now increased prevalence of asthma is being reported from most of the countries. Like in the previous literature used to say that the underdeveloped countries or the so-called developing countries are reporting less prevalence, like the Asian countries in India, they are reporting less prevalence in comparison to the Western world. But now that industrialization has took over and the Western lifestyle has took over even the developing countries, the prevalence is kind of catching up or it is similar. So there is no racial disparity or there is no geographic disparity as of now, right? Okay, so that's the first point we need to address about epidemiology. Now, before we go to pathology and pathophysiology, we need to understand the risk factors. Okay, now when I say risk factors, they need not mean the asthma triggers. So we need to differentiate between the asthma triggers and risk factors. Risk factors are those factors, epidemiological factors or exposures. Could be both. It could be epidemiological factor or an exposure factor, which increases the risk of development of asthma. The asthma triggers are the one where you have already developed asthma, you have a proneness to bronchoconstriction or bronchospasm, and then exposure to that particular substance precipitates an asthma attack, right? So that's trigger, right? So let us look at the risk factors. Now, when we talk about risk factors, obviously we have to begin with genetics. And it has been noted that around 25 to 80% of monozygotic twins, right, share asthma occurrence. So that means the concordance rate is reasonably high, and that suggests that genetics do play a very, very important role. There is significantly important role of environmental factors, but genetic predisposition also is a major factor, right? Now, the important genetic factors that you need to remember that increase the risk of bronchial asthma are mutations or variants of ORMDL3, GSDMB, then ADAM33, interleukin 12 and interleukin 33 polymorphisms. Okay, I particularly want you to remember interleukin 33 polymorphism because this increases or predisposes to non-type 2 bronchial asthma. Non-type 2 bronchial asthma. Okay, so today we classify bronchial asthma instead of classifying it as intrinsic and extrinsic. We classify them into type 2 inflammation mediated bronchial asthma and non-type 2 bronchial asthma, right? So certain polymorphic variants of IL-33 increase the risk of development of the non-type 2 bronchial asthma. Okay. Now, when we talk about genetics and when we talk about a chronic disease, obviously the HLAs also come into picture, right? So here HLA-DQB1 and HLA-DQB2. These are the two HLA variants which are associated with increased risk, right? So please note, generally when we talk about HLA, we will be talking about HLA-DRB1. Like when you talk about rheumatological disorders or other autoimmune disorders, we talk about HLA-DRB1. Here it is not DRB1, it is DQB1 and DQB2. So please do not confuse. If there is a question asking you which of the following HLA variant increases the risk of development of asthma and you see HLA-DRB1, by solving multiple MCQs, we would have come to a subconscious tendency to pick up DRB1 as the right answer whenever a question is about HLA, right? Here it is not HLA-DRB1, it is DQB1 and DQB2. Clear? Okay, so that is about genetic predisposition. Very, very important because 25 to 80% of the risk can be explained from the genetics. Okay, but the remaining risk needs to be explained by exposures, right? So allergen exposure comes into picture. Now, if there is an MCQ asking you, what is the most common allergen that has been implicated in causation of asthma, right? Okay, remember one important point. Anything that has a causal relation as an exposure, has a causal relation with asthma can also be a trigger factor. But all trigger factors need not be associated with causal relation, right? Like if there is a trigger factor on exposure to which, like for example, dry air or cold dry air, that can be a trigger factor. But it is not going to cause asthma. It will not make a normal individual to develop asthma. But an asthmatic, if exposed to cold dry air, will have a precipitous fall in the lung functions, right? Okay, so I'm talking about allergen exposure, and if there is a question asking you what is the most commonly implicated allergen in the pathogenesis of bronchial asthma, your answer has to be house dust mites. House dust mites. House dust mites. Okay. Apart from that, there are various other factors like the pollutants in the air. There can be occupational exposure to allergens. But if the question is about the most common, please remember it is house dust mites. Allergen exposure can be associated with a causal relation with bronchial asthma. Okay. Now, whenever you talk about allergen exposure and there is development of bronchial asthma, mostly it is the eosinophilic inflammation mediated as well as your IgE mediated, right? So this is usually associated with type 2 inflammation mediated bronchial asthma. Type 2 inflammation mediated bronchial asthma, right? Because allergen should induce cells to produce the IgE as well as the eosinophil, and the eosinophilic inflammation as well as mast cell degranulation is responsible for the airway inflammation and the other changes that we will see. Okay. Now, tobacco smoking and even consumption of tobacco in other forms like chewing is also considered as a risk factor. It can probably have some association in causation of bronchial asthma. And same thing we can say about bronchial asthma and infections. When we talk about infections, you need to remember it's mostly viral infections like rhinoviruses and RSV, right? And mycoplasma pneumonia. I know mycoplasma pneumonia is our atypical organism, right? Mycoplasma pneumonia. These three have some evidence to say that there may be a causal relation, though not conclusively proven. If at all some examiner in your PG exam asks you which viral infections can be the cause for bronchial asthma, this is what you can answer: rhinoviruses, RSV, and mycoplasma pneumonia. Now, one important point I want you to note about all these is the tobacco exposure, air pollution, and infections. These are not allergens, right? So these do not cause the so-called type 2 bronchial asthma. These cause non-type 2 bronchial asthma. Okay, so remember in non-type 2 bronchial asthma, the airway inflammation is mainly because of the neutrophilic infiltration of the airway. So it is neutrophilic inflammation. In case of type 2, it is eosinophilic inflammation. Eosinophilic inflammation, and also there is some extent role of IgE in recruiting mast cells, and there is mast cell degranulation, right? So there is no neutrophilic inflammation in case of type 2, and there is no eosinophilic inflammation in case of non-type 2. Clear? Okay. Now, moving on further, as I've already told you, certain occupational exposures may be associated with the trigger for asthma. Typically more common in adults, right? So, because most countries have a ban on child labor, childhood exposure to occupational agents is limited. But once you achieve adulthood and start going to your work, certain industries may be associated with increased risk of development of asthma. But again, there is one important point we need to note here. We need to differentiate another entity called RADS from bronchial asthma. Okay, some of you might have already been aware of what is called as RADS, and some of you may not be. Right? RADS versus occupational asthma. Okay, so what this RADS stands for? RADS stands for reactive airway dysfunction syndrome. Airway dysfunction syndrome. Okay. Now, what is the reactive airway dysfunction syndrome? Because see, sometimes in the past, many doctors used to call asthma also as reactive airway disease, right? Now, we no longer use the terminology. Bronchial asthma is a specific diagnosis. Okay, imagine a circumstance where you're first time getting into an industry and suddenly there is large load of particulate matter thrown out into the air and you end up inhaling large load of that particulate matter. Will you come out asymptomatic or will you develop some kind of symptoms? Right? Whenever we are exposed to large dose of particulate matter or large dose of ionizing substances, right, or large dose of oxidizing substances in the air, right, we can develop airway inflammation. And that can lead to bronchoconstriction, right? So these patients can come out wheezing, but these are not asthmatics. These are not asthma. Okay, so how is it different from occupational asthma? In occupational asthma, exposure to the agent, whatever is responsible, right? The repeated exposure to the agent leads to airway sensitivity, right? So there is airway sensitization. So once there is sensitization, when the second time exposure occurs, even smaller quantity of that particular allergen can trigger an asthma episode. But in case of reactive airway dysfunction syndrome, right, when the second time exposure occurs, if it is a small quantity exposure, it will not trigger because there is no sensitization. It will not trigger an asthma episode. Only when there is large particulate load in the ambient air, patients might have symptoms, right? So it is the reactiveness of the airway because of a large load of the particulate matter or because of the high dose of oxidizing or high dose of ionizing substances in the air. It is not because of the airway sensitization. That is the difference, right? So these patients may be able to tolerate small quantities of the same particulate matter in the ambient air, right? So the simple thing, if you want to minimize the risk of reactive airway dysfunction syndrome, give them the N95 masks when at workplace. That would solve the problem. But your occupational asthma patients might continue to experience symptoms if they are challenged even with small, and as the time progresses, even smaller challenges might trigger the asthma in them, right? Clear? Okay. Now, occupational asthma, I will discuss more when we discuss the variants of asthma. For now, just remember that industrial exposure to certain allergens or certain irritating substances may be one of the trigger factor as well as the reason for initiation of asthma. If there is possible causal relation here. Okay. Now comes the question of diet in causing asthma, diet and nutrition. Now, the relation with food and development of asthma is not well established. Food allergies might manifest with the eosinophilic inflammation of the gut, eosinophilic esophagitis, eosinophilic gastroenteritis. But the direct relation with asthma is not well established. Nonetheless, patients do continue to practice, doctors do continue to advise to avoid the food items where the patient is known to be allergic, but the direct causal relation is not well established. Okay, so please remember that point. Now, coming to what is known, which is of clinical significance when it comes to diet and asthma. It has been noted that vitamin D deficiency is associated with slightly higher risk of development of asthma. There is increased risk of development of asthma, and also in a pre-existing asthmatics, vitamin deficiency is associated, vitamin D deficiency is associated with more severe episodes and high frequency of the asthma attacks, right? So the episodes can be severe, increased severity of asthma attacks and increased frequency of asthma attacks in patients with vitamin D deficiency. Clear? So there may be some causal relation which can be debated because strong data is not there in favor of it, but possible role is there. Now we talk about vitamin D deficiency in most of the chronic diseases, right? Okay. Apart from that, there are also studies which show that deficiency of zinc and vitamin C in the prenatal period, like maternal deficiency of zinc and vitamin C, may be associated with the asthma in the newborns and offsprings, right? So it may be associated with increased risk of asthma in newborns or children, increased risk of asthma in the children born to people who had zinc or vitamin C deficiency during prenatal period. Clear? Okay, so that's about the diet and nutrition. So all you need to remember is vitamin D, which might have some causal role. Time will give us an answer whether it gets established or whether it gets refuted. But at least once the asthma has set in, vitamin D deficiency is associated with increased frequency and increased severity of asthma attacks. So it's all the more important that you screen the asthmatic patients for vitamin D deficiency, particularly when they are non-responsive to the conventional treatment. And if found, replace it. Okay. Now, coming to obesity, many doctors do agree that obesity might have some causal relation with the asthma. The reason for that is obesity is associated with production of certain adipocytokines and inflammatory cytokines, right? So during obesity, there is production of adipocytokines, which itself have inflammatory properties, and in patients with obesity, even interleukin 6, which is one of the important inflammatory cytokine, they are upregulated, and this can be associated with, this can play some role in airway inflammation. Okay, so how confident I am to say that, okay, there is definite role of obesity in asthma causation? Probably, I'm not very sure. But what do we agree is that obesity is definitely a risk factor. Obesity is associated with increased prevalence of asthma. Like obese people have higher prevalence of asthma, and in obese individuals, the asthma attacks are likely to be more severe than non-obese individuals, right? Okay, that is one thing. Now, coming to medications, can medications have a role in the onset of asthma? Okay, again, one more important debatable factor. Once the asthma diagnosis is well established, one patient has developed asthma, like beta blockers and various other medications may be associated with the precipitation of asthma attacks, right, or worsening of asthma control. But medications as a cause for development of asthma is not proven, right? So right now, I have no strong evidence to say that any particular medicine is associated with the increased risk of asthma. Okay, prenatal exposure to certain drugs, like for example, acetaminophen or paracetamol, right? Paracetamol prenatal exposure may be associated with increased risk of asthma, but again, a debatable factor, right? There is no strong data to say that it is indeed a risk factor. But please be aware that there is a possibility. Prenatal exposure of certain drugs, like when you're treating a pregnant female with certain drugs, that might increase the risk of asthma in the offsprings. Clear? Okay. Now, when we are talking about prenatal, there are other factors which are reasonably well established to be risk factors for asthma. That includes if mother suffers from preeclampsia, or if there is a premature baby born, or if the baby is born out of cesarean section, or if the baby suffers from neonatal jaundice, right? All of these are associated with increased risk of asthma. Okay. And it has also been noted that breastfeeding is a protective factor. Breastfeeding is a protective factor which reduces the risk of asthma, at least in the initial few years. Whether it reduces the asthma risk over the lifetime, we don't know, but at least in the initial few years, it does reduce the risk of bronchial asthma. So, one more reason that we should encourage the breastfeeding, right? Okay, so that was about the risk factors. Now, having done a quick review of risk factors, it is time for us to address the trigger factors. As I've already told you, risk factors are different from trigger factors. Risk factors are either those non-modifiable risk factors that include the genetics, and the modifiable risk factors which are about exposure to allergens, occupational exposure and all, right? The trigger factors are purely related to exposures or other factors, which trigger factors are almost always modifiable, right? Okay. Now, what are the asthma triggers that we know? Number one, most common trigger is again allergen exposure. Right. So if you are allergic to something and that has already initiated or incited asthma and you have continued exposure, then you will have repeated attacks of asthma, allergen exposure. Second thing is your air pollution. Once you have developed asthma and you are pre-sensitized, right, particulate matter load in the ambient air also matters, right? That's why during the worst days of air pollution in Delhi, we start seeing a lot of cases of asthma and COPD having precipitous fall in lung functions and presenting to emergency OPDs, right? Okay. The third trigger factor and a very important trigger factor is infections. Any upper respiratory tract or lower respiratory tract infection, respiratory tract infections per se can be a trigger, right? Okay. Then the fourth trigger that you need to know is ambient air temperature, right? So cold and dry air can trigger asthma. The reason this cold and dry air can trigger asthma is cold and dry air exposure is associated with dryness of the airway, right? So once the airway becomes dry, this somehow leads to mast cell degranulation. Mast cell degranulation. So the mast cells degranulate and release. What are the inflammatory mediators released by the mast cell? Yes, prostaglandin D2 and histamine, right? And now you know the vasculotoxic properties of the histamine, so that causes vasodilatation, right? And your prostaglandin trigger other inflammatory cytokines to cause airway inflammation. Once there is airway inflammation, obviously there is an asthma attack, right? So that is why most of the asthma attacks occur in the wee hours or early morning hours, right? Because that's the time where the ambient temperature is very low and one may be exposed to dry air, right? Okay. So if there is a question asking you what is the most important trigger factor for asthma episodes in a patient who was well controlled on medication, then the answer has to be infections, right? So today infections are a very important reason why a well controlled asthmatic presents to hospital with worsening of their asthma control. Okay, so this is about the trigger factors. Now most of these are avoidable, right? Allergen exposure possible if you know what is the allergen or what is the trigger, right? Air pollution is avoidable if you don't live in a polluted city, or at least you can use a mask which has a good property of at least 2.5, right? Or you can say N95 masks. And then the ambient air temperature, not fully avoidable, but at least if you know that you're asthmatic and the exposure to cold air triggers asthma, maybe you can avoid the air conditioned places, or you can keep the humidity as well as the temperature of the enclosures or your rooms well under control, right? Okay, so that's about the asthma triggers. Now there are also certain comorbidities which may be associated with poor asthma control or higher symptomatic load of the asthma, right? What are those? Obesity. I have already discussed obesity might have some causal role, and once someone is obese, right, the tolerance of the PFT changes that occur in an asthmatic is poor, right? So in asthmatic, the peak expiratory flow rate is reduced. There is air trapping, and because of the obesity, the diaphragm is generally pushed into the thorax, so there is less space available for the lungs to expand, so they will not be able to tolerate asthma symptoms well, so they become more symptomatic, right? So obesity can increase the asthma severity, or overall the asthma control can be little poor in obese individuals. Similarly, having GERD. Okay, so previously some editions of the Harrison and some doctors or some authorities used to talk about GERD as a cause factor for asthma. Now we today clearly understand GERD has no causal relation with asthma. But if you are asthmatic and you have GERD, now GERD episodes may be associated with increased asthma attacks, because possibly because of the micro aspirations into the airway. Micro aspirations of the reflux fluid into the airway may be associated with increased frequency of asthma attacks. Okay, and we have to also remember when we talk about asthma, right? If at all we end up treating an asthmatic with oral steroids, right? That increases your GERD symptoms, and there may be a relation, a kind of a vicious cycle. You give steroids, the GERD symptoms worsen, and worsening GERD symptoms will also lead to worsening of the asthma frequency or attacks. So I need to keep that in mind. Okay. Now, apart from that, having rhinosinusitis or vocal cord dysfunction may be another other factors which are associated with a poor asthma response to management. Right. Now, when you have rhinosinusitis, there is constant load of infective viruses or bacteria given to the airway, and we know that infections are an important trigger factor. Right. So there may be repeated triggers because you have rhinosinusitis. Clear? Okay, now I hope you have understood the difference between the triggers and the risk factors. Okay, now comes the point of understanding pathophysiology. But before we go to pathophysiology, right, let us talk about what are the changes if you have an asthmatic and you take a section of the section of his airway. What are the changes that you're going to expect, right? Because see, asthma initially starts with the inflammation and bronchoconstriction, but over time, what there is something called as airway remodeling, right? So over time, there are irreversible changes occurring in the airway. So after that, even if the allergen exposure is no longer there, the airway is modified, right? So that airway remodeling changes is what we need to remember. So what are the changes that we can anticipate? Airway remodeling. Number one, right? So the number one and probably very important one is that there is thickening of the basement membrane. Thickening of the basement membrane of the airway epithelium. Why there is thickening of basement membrane of the airway epithelium? Probably there is recruitment and activation of fibroblasts which deposit more and more collagen. Right now, how this becomes a problem? Because of the thickening of the airway, right? So airway starts becoming stiff in the long run. Thickening of the airway basement membrane. That is one point. Okay. The second thing you notice is there is airway smooth muscle hypertrophy. Airway smooth muscle hypertrophy. This is one of the genuine problem of an asthmatic. Now, this is I generally compare it to sending your airways to gym, right? So when you are exposed to some allergen and your smooth muscles as a response to that constrict, and there is continued or repeated exposure to allergens, the smooth muscles are constricting again and again. And just like how we go to gym and practice and we bulk up our muscles, similarly the smooth muscles in the airway get bulked up over time because of repeated exposure to allergen. But once they are bulked up, once there is hyperplasia and hypertrophy of the airway smooth muscles, right? Progressively, less quantity of allergen is required to trigger a very severe constriction because the muscle mass is increased, right? So this is one area which can be addressed in treatment, right? If you can probably shrink this smooth muscle mass, then the airway hyperresponsiveness would reduce, right? So probably patients can tolerate larger allergen exposures if the smooth muscle shrinks in its dimension. Is that possible? Yes, that's possible. We could do that with what is called as bronchial thermoplasty. Bronchial thermoplasty. So there was a lot of hope based on the bronchial thermoplasty, thinking that okay, this will become one of the pioneer treatment of bronchial asthma in the near future. But what we have learned in last couple of years is that the result is not very promising. It is associated with myriad complications, and we probably need more time to identify a right set of individuals who can benefit from the bronchial thermoplasty. So right now, GINA in 2021 and 2022, it recommends that bronchial thermoplasty is currently reserved only for those individuals who are recruited in clinical trials, not for routine use, right? So if you are doing a clinical trial trying to understand if bronchial thermoplasty is useful in a setting, maybe you can do that. So there is no role for routine use right now. Clear? Okay. Now the third change we will be seeing is goblet cell hyperplasia. Goblet cell hyperplasia. So the number of goblet cells would have significantly increased. Now we know what is the role of goblet cells. They will be producing mucus, right? So there will be increased amount of mucus produced, right? So that will have this mucin protein, and that confers a very tenacious nature to the sputum, right? And you know that asthmatics sometimes struggle to bring out the sputum because of the thick viscid nature, and that comes from the goblet cell hyperplasia. The fourth change that you will be noticing is the airway inflammation. Airway inflammation can either be neutrophilic or it can be eosinophilic. It can be either neutrophilic. If it is neutrophilic, that is where you call it as non-type 2 bronchial asthma, and if it is eosinophilic, where basically the cascade begins with activation of Th2 T cells, right? Then it is eosinophilic. Now, most cases of eosinophilic asthma also, if there is acute trigger and there is acute precipitation, there may be some degree of neutrophilic infiltration involved. Clear? Okay, so these are the four important changes that we see when you take a section of the airway of a patient with asthma. This image gives you a clear perspective of what I'm talking about, right? So there can be goblet cell hyperplasia. Thus, the mucus glands are increasing in number and the goblet cells are increasing in number. So there is more tenacious mucin production, right? So that in a very severe asthma, sometimes there may be mucus plugging of the distal airways are loaded with the thick, tenacious, viscid mucus, which couldn't be expectorated by the patient, right? Okay. Now, increased smooth muscle mass is what I have already told you. So you can see that the smooth muscle mass here, it is increased, right? Okay. Then the subepithelial fibrosis, that is what I wrote as the thickening of the basement membrane. And the thickening of basement membrane also means that there is more severe asthma coming forward, right? Okay. And I forgot to tell you about the angiogenesis. So in asthma also there is increased amount of new blood vessels formed, right? I will talk about its utility as we go along, right? How it influences the asthma progression, right? So there is increased angiogenesis also. And once there is increased angiogenesis, the amount of inflammatory mediators delivered to airway increases, right? And it will have an influence on the diffusion capacity of the gas, or DLCO. Okay, so if there is angiogenesis and vascular inflammation, the DLCO can be increased. Okay, we will talk more about it later. Okay, yeah, I also forgot to tell you about the epithelial alteration. So the changes in the epithelium also mean that the airway hyperresponsiveness increases. So as the time progresses, need for the higher doses of the allergen exposure keeps declining. So you need lesser and lesser quantity of allergen as the time progresses to bring about an asthma attack, right? So one of the important changes is the decrease in the protective barrier. So epithelium acting as a protective barrier now having gone through the destruction because of the inflammation, right? So there is no barrier and the allergen can be easily delivered to the inflammatory cells. Clear? Okay, so from there, having understood what changes we are seeing, now comes the time to understand the molecular pathophysiology. Previously, we used to classify asthma as intrinsic asthma and extrinsic asthma. Now that we have a molecular understanding of asthma, it is better to classify asthma as the type 2 inflammation mediated asthma, or you can simply call it as type 2 asthma and non-type 2 asthma, right? So now this is type 2 asthma and we have non-type 2 asthma. Now it is basically called as type 2 asthma because in type 2 asthma, one of the principal cell that is involved in the pathogenesis is the Th2 cells, right? Because of that, it is called as type 2 asthma. Now around 50% of the asthma cases are type 2 and some literature mentions around 40 to 70%. So roughly you can say that type 2 asthma is slightly more common in comparison to non-type 2 asthma, right? Okay, is that clear? Now in type 2 asthma, the initial inciting agent is usually an allergen, right? It is an allergen. So it is, you can compare it to or these patients are more likely to have the history of atopy, right? And these patients are more likely to be allergic to other substances. So when an allergen is delivered to the airway epithelium, so this is your airway epithelium. When an allergen is delivered to airway epithelium produces something called as thymocyte stromal lymphopoietin, right? So it is a inflammatory mediator, thymocyte stromal lymphopoietin, and this TSLP stimulates production or stimulates activation of the Th2 response. So your type 2 helper cells are recruited and are activated because of this TSLP, and this TSLP also recruits the ILC2, right? It is one more lymphocyte which is recruited into the inflammation. So ILC2 and Th2 are the two important cells. The most important cell you need to remember is Th2 itself. Now this Th2 activation leads to production of interleukin 4, 5 and 13, three important mediators. These mediators are called as the type 2 mediators. These are called as type 2 inflammatory mediators, right? What are the mediators I'm talking about? I'm talking about interleukin 4, interleukin 5 and interleukin 13. And we are already familiar about interleukin 4 and 5 because we are using these as targets for drugs, right? So when we talk about dupilumab or benralizumab, reslizumab, we are basically targeting interleukin 4 or interleukin 5. Now what this interleukin 4 particularly does is, interleukin 4 stimulates the B cells to cause a switch to IgE producing cells. So interleukin 4 stimulates B cells, right, and stimulates the transition from the conventional B cells to IgE producing B cells, or you can say IgE producing plasma cells, right? IgE producing plasma cells. Now these IgE molecules produced by the B cells and plasma cells, these IgE molecules then can stimulate the recruitment of mast cells. And once the mast cells are recruited to the site of inflammation, mast cells will degranulate and release prostaglandin D2 or prostaglandin 2 and histamine. Now this histamine causes vasodilatation and inflammation, right? Vasodilatation and inflammation. And prostaglandins also cause inflammation. And this sets in the subsequent cascade of pathway that leads to the changes that we just discussed, right? So that is the role of Th2 cells. Th2 cells are basically producing IL4, IL5 and IL13, and IL4 is the one which is concerned with causing the B cells to switch from the conventional B cells to IgE expressing B cells, and once they start producing IgE, that IgE stimulates recruitment of mast cells. Okay, now the second change that you notice is from IL5. What IL5 can do is IL5 can recruit eosinophils, right? So IL5 can recruit eosinophils, and we know that eosinophils can also cause eosinophilic inflammation. So eosinophils can also lead to inflammation. So the prostaglandins produced by the mast cells and histamine produced by the mast cells and eosinophils are all going to cause airway inflammation. Now this is one important point you need to note, right? So as I have drawn this, interleukin 4 is concerned with the IgE switch of B cell. So in any condition where the IgE, like an asthmatic where IgE is elevated, probably you can treat them by giving IL4 blockers, either directly blocking the IL4 or its receptor on the B cells. Probably you can help an asthmatic because that reduces the IgE levels, and once the IgE levels are reduced, the mast cell recruitment is reduced, and thus the prostaglandin 2 production as well as histamine production is reduced, and the end result is inflammation is reduced. Okay. On the other hand, right, if you block IL5, then the eosinophilic recruitment will be reduced. So you can give IL5 drugs in patients where the eosinophil count is high. You have an asthma with high eosinophil count, you may be benefited by IL5 blocker, right? You probably do not derive benefits if, like, the IL4 drugs can be used whether your eosinophil count is elevated or not, as long as the IgE is elevated. But IL5 drugs cannot be used if the eosinophil count is not high, because that means the eosinophil mediated inflammation is not contributing to the severity of asthma, right? So if eosinophil count is normal, you cannot use IL5. So that we understand from this pathophysiological flowchart. Okay, so this is about the type 2 bronchial asthma, right? So I'm just repeating myself. Th2 cells are the main principal inflammatory mediator cells in case of type 2 asthma. That's why it is called as type 2 inflammation asthma, right? And here the trigger factor, or the inciting factor I should say, is the allergen, right? So it is an allergy triggered event. Now when it comes to non-type 2, here the principal cell is not the Th2 cell, indeed it is the Th1 and Th17 cells, right? And here there is no allergy involved, so allergen is not required. Any viral infection, irritants, right? Viral infection or infections per se, not only viral, even bacterial infections or exposure to irritants or pollutants, all of them can cause the asthma here, right? So all of them can be trigger factors and inciting factors. Now these infections or irritants or pollutants can irritate the airway, leading to production of interleukin 13 by the airway epithelial cells, and that becomes the first important cytokine. Now this interleukin 33, I have already spoken about interleukin 33 when we discussed the genetics, right? So I told you that certain polymorphic variants of the interleukin 33 gene are associated with increased risk of bronchial asthma, particularly the neutrophilic inflammation, right? So here this interleukin 33 is increased in production because of the irritation of the airway epithelium by infections, irritants or pollutants. The other thing you might notice is if it is infection, right, there is also production of interleukin 6, which is again an inflammatory cytokine, right? So whenever there is an infection, as a response, interleukin 6 may be produced. Now we are all familiar about interleukin 6 now because of the COVID. During COVID, we started evaluating patients' inflammatory cytokine load by looking at interleukin 6, right? Okay. Now this interleukin 33 leads to recruitment and activation of the Th17 or the 17 helper cells. And these 17 helper cells will start producing inflammatory cytokines that are IL6, IL17 and interleukin 8. 6, 17, and 8. And these inflammatory cytokines will stimulate and recruit the neutrophils to the site of inflammation, and there will be neutrophilic inflammation. In case of non-type 2 inflammation asthma, there will be neutrophilic inflammation. There is no major role of eosinophils and IgE here, right? Okay. Similarly, there may be activation of Th1 cells, and we know that when there is activation of Th1 cells, that stimulates production of the interferon gamma, eventually TNF alpha. They also can contribute to recruitment of neutrophils, right? So the point is clear. Now, tomorrow you have an asthmatic who is not responding to your conventional medications. Then we have certain monoclonal antibodies which are targeting IL-4 or IL-5. They will be useful in a patient with the type 2 bronchial asthma. In the non-type 2 bronchial asthma, they may not be very helpful. Clear? So these continue to be refractory to those medications also. And also we have to remember that whenever we talk about eosinophil being responsible for inflammation, the condition is likely to be responsive to steroids. So between the non type 2 and type 2, again type 2 is more likely to be responsive to steroids. So when you talk about eosinophilic esophagitis, when you talk about eosinophilic gastroenteritis, there is good response to steroids, and there can be good response to asthma also when you start treating them with inhaled or in severe cases with oral steroids. You cannot expect the same great result when it comes to non-type 2. There may be, because even neutrophilic inflammation can be suppressed with steroids, but relatively less steroid responsive. Non-type 2 are relatively less steroid responsive. Clear? Okay. So that's about the pathophysiology of asthma. Now we come to the diagnosis of asthma. Now, from MBBS days, we have been hearing that everything that wheezes is not asthma, and which I cannot reinforce how important this factor is, because in a busy OPD, right, the moment you see that someone presents with cough and wheezing, we ended up branding them as asthmatics many a times, right? But that's definitely false, or that's definitely wrong, right? Ideal way is the diagnosis of asthma is purely PFT based. It's purely PFT based. Clinical examination and history is always important regardless of what disease you're treating, but final diagnosis, final confirmation is based on PFT, not based on your clinical judgment, not based on your history, right? It is always PFD based, and PFT parameters are something that we need to remember, right? Okay, but nonetheless, we do take a good history, and when you take history, I particularly want you to remember, right? So if patient presents with wheeze and breathlessness, we will definitely think asthma as our priority number 1 differential, and then we will think of COPD, infections, and other causes as priority number 2, 3, 4 differentials. But sometimes patients might present with purely cough. So one needs to be aware about what is called as cough variant asthma. Cough variant asthma, right? So cough may be the only presenting complaint in some individuals. Again, cough variant asthma, we will discuss more about it when we discuss the variants of asthma. But for now, remember that cough itself may be the sole presenting complaint. They may not come and present with wheeze, right? When you auscultate in a patient who presented purely with cough, wheeze may be heard, or sometimes it may not be there, but cough may be the only complaint. But still, even in a cough variant asthma, it will meet the diagnostic criteria of PFT. Right? If someone presents with chronic cough and PFT is not suggestive of asthma, you cannot call it as cough variant asthma. Clear? Okay. So history is important, and when you gather history, you need to pay attention to cough as the sole complaint. Apart from that, you also need to pay attention to occupational exposure. Occupational exposure. The reason for that is, again, occupational asthma and RADS you need to differentiate, because the approach to management may be different. If it is RADS, then it is only about reducing the exposure to the load of the particulate matter, right? Even a mask might solve the problem. But when it comes to occupational asthma, then sometimes there may be need for change of the occupation itself, right? So we'll talk more about the occupational asthma when we again talk about the variants of asthma. Okay, and whenever you take history of asthma, there is very important factor with respect to triggers. You need to make an attempt to identify the trigger factors and relieving factors, because one of the important reasons why asthma is poorly controlled in at least some of the individuals is continued exposure to trigger. So trigger mitigation is very important. Like for example, if someone who is allergic to, let me say, certain pollens, now no matter what dose of inhaled steroids you give, no matter what dose of oral steroids or monoclonal antibodies you start, if there is continued exposure to the triggering factor, patients will continue to experience the asthma episodes, right? So you need to at least make an attempt. It is not always evident, it is not always clear Like patient may not give you a history very typically suggestive of exposure to allergen, then development of symptoms. But we should make an attempt for sure, right? Okay, so that's about the history. And then when we examine a patient of asthma, on examination, what are we expecting, right? We all know that we will be expecting the V's. And when you pay attention to the breathing, you will notice that expiration may be slightly longer. The duration of expiration may be slightly longer than inspiration, right? Because whenever you talk about an obstructive lung disease, whether it is COPD or bronchial asthma, the obstruction predominantly affects the expiration than the inspiration. The reason for that is we all know inspiration is an active process, right? So when we start inspiration, a negative interthoracic pressure needs to be created, and that is brought about by the diaphragmatic descent, right? And the expansion of the chest cavity, so that there is a negative intrathoracic pressure created so that the lungs can suck in the air, right? So it's an active process. Your muscles are involved in it. But expiration is a passive process. Expiration is merely because of the passive recoil of the chest wall and the return of the diaphragm to its position. So it's not an active process, right? So even when the airway is narrowed during inspiration, the airway narrowing can be overcome by this active effort, right? But when the air needs to escape back, there is no active contraction of the chest, right? There is no active contraction of the diaphragm to push the air out. And because of that, the expiratory obstruction cannot be overcome by the body, right? So that is why expiration is more affected in case of any obstructive lung disease per se. So because of that, expiration takes longer time, so expiration duration can stretch. Inspiration remains unaffected, but the expiration duration can stretch. And when you hear V's you probably better appreciate during expiration, right? So you might have a V's heard both in inspiration as well as expiration, but it is more heard in expiration, right? More heard in expiration. And that is why when we do PFT of patients with asthma, right, for follow-up, we are not looking at the amount of air that patient can inhale. We are not looking at the tidal volume or total lung capacity of these patients. We are interested in peak expiratory flow rate, right? Because expiration is what is we are concerned about, or what is we are interested in a patient of bronchial asthma. Clear? Okay. Now, having gone through this, we should also remember that V's or rhonchi need not always be heard, right? As the condition progresses and the subepithelial fibrosis increases, the V's can start becoming minimal because even the airway becomes constricted and stiff, and the constriction and relaxation gets reduced. So, in a more severe and advanced asthma, the V's or rhonchi may be minimal or reduced, but patient will have the obstructive defect, right? Because the airway is obstructed and fixed. To start with, it was variable, but then eventually, in more severe and advanced cases, it might become fixed. It might start behaving a little more like COPD, right? And the second thing is when there is very severe attack of asthma. In a severe attack of asthma, the chest may be silent, and that is more of a major concern, right? So a silent chest should be in a strongly suspected asthma patient. A silent chest should signify that you are probably dealing with a severe attack of asthma. Right? If you're hearing V's, that means there is still airflow occurring. When you don't hear V's, the airflow is limited, right? Okay, so that's about examination. And as I've already told you, the diagnosis is purely PFT based. So on the PFT, what are we expecting? Okay, so we're talking about an obstructive lung disease. Asthma is an obstructive lung disease with variable obstruction, and that's how we differentiate it from COPD. COPD is an obstructive lung disease with fixed obstruction, right? So in COPD, the airway is narrowed and the obstruction is not much variable. But in case of asthma, airway can assume the normal diameters. It can get constricted very severely on exposure to allergen, and in the absence of exposure to allergen, it can come back to its normal size, right? At least in the initial few years of asthma. So that is what we try to demonstrate, so that we differentiate between asthma and COPD, because both are obstructive lung diseases. Asthma and COPD both are obstructive lung disease, and we need to differentiate between these two. So to start with, what we do is your FEV1 levels, and FEV1 levels will be decreased. Forced expiratory volume, I have already discussed why expiration is affected more. So forced expiratory volume, FEV1, will be reduced in both asthma as well as COPD, right? Okay, now the next thing we see is FEV1 by FVC ratio. FEV1 by FVC ratio, forced vital capacity. The obstructive lung disease and restrictive. So this ratio is basically done to differentiate between obstructive and restrictive lung disease, right? So in case of, let me say, restrictive lung disease. In restrictive lung disease, there is restriction to the lung expansion, right? So your forced vital capacity will be reduced, and your FEV1 per se in a restrictive lung disease may be reduced because of the overall restriction, or may be normal, right? It can be normal or reduced, but the major impact is on the forced vital capacity. And when we talk about obstructive lung disease, obstruction is more to the flow of the air, not to the expansion of the lung. So the forced vital capacity in an obstructive lung disease patient will be normal, or because of the restriction to expiration, with passage of time there may be air trapping, right? So because you'll not be able to expire everything that you inhaled, so you may be trapping air, and because of that forced vital capacity may be increased, right? But definitely you will have reduced FEV1, right? So what happens to the ratio in that case? The FEV1 will be reduced, forced vital capacity is normal or increased, so the ratio will be lower, right? So in an obstructive lung disease, this ratio will be less than 0.7, or if you want to express in terms of percentage, less than 70%, right? So if it is more than 70%, you can think of restrictive lung disease. If FEV1 is reduced, forced vital capacity is reduced, and your ratio is more than 70%, you can think of restrictive lung disease. But when FEV1 is reduced, FVC is normal, right, or increased, and you have a FEV1 by FVC ratio less than 0.7 or 70%, you think of obstructive lung disease. Now, till now, it is possible that it could be asthma or COPD. In COPD also, FEV1 will be reduced, FEV1 by FVC ratio will be reduced less than 70%, right? Now, how do we differentiate between these two? As I've already told you, when we talk about COPD, we are talking about fixed obstruction, right? Fixed obstruction. But when you talk about asthma, there is variable obstruction. And this variability is what we need to demonstrate to say that, okay, this is a case of asthma. So how do we demonstrate variability? The variability can be demonstrated by giving a inhaled bronchodilator to the patient, right? So you can give an inhaled bronchodilator to the patient, and you can repeat the FEV1 parameter after giving the bronchodilator. And this is what we call as bronchodilator reversibility test, or BDR test. So after administration of a short-acting, immediate onset short-acting beta agonist, right? If you do the FEV1, if FEV1 increases, right, FEV1 increases by more than 12%, more than or equal to 12%, or by an absolute value, it increases by an absolute value of more than or equal to 200 ml, right? Then you can say the bronchodilatory test is positive, and that means the airway obstruction is reversible, and then you can stick to the diagnosis of asthma in that case. If it is less than that, let me say like 6% or 7% improvement in FEV1 is noticed after giving a short-acting beta agonist, that suggests that the airway obstruction is not fully reversible, and in that case you can think of COPD as the diagnosis, right? Okay, so is that clear? Increase by more than or equal to 12%, or increase by an absolute value of more than or equal to 200, right? If either of that is met, then you can say there is variable obstruction and your diagnosis is asthma. Okay, now if at all there is a circumstance where you cannot do this bronchodilator reversibility test, right, in those cases you can also try with oral steroids. When you give oral steroids for a period of around 2 to 3 weeks and reassess the PFP, and if FEV1 increases after administration of steroids for 2 to 3 weeks by more than or equal to 12%, or by an absolute value of more than or equal to 200 ml, you can say the bronchodilator reversibility test is positive even in that case, and you can consider the diagnosis of asthma. Clear? Okay, so these are the basic things we need to know about the diagnosis of asthma. If you ask me what is the role of peak expiratory flow rate in case of asthma, when it comes to adult asthma, the peak expiratory flow rate is basically used for monitoring of the asthma. It is not principally right now used for the management of asthma. It can be used for monitoring the asthma, whether the patient is not doing well with the inhaled corticosteroids plus the bronchodilator medication that you would have prescribed, and also for assessing the compliance with respect to medication. It doesn't find a place right now in the diagnosis of bronchial asthma. Clear? Okay. Apart from these PFT, we should also be aware about what we call as other things, that other lab tests that we can do in an asthma patient, that includes assessment of airway hyper responsiveness. How can you assess the airway hyperresponsiveness, because asthma definition basically says that the airway is hyperresponsive to exposure to certain substances, and it reacts by vasoconstriction or bronchoconstriction, right? So how can we prove that the airway hyperresponsiveness is there? Because see, when I spoke about RADs, I told you that large load of particulate matter reaching the airway triggers the bronchoconstriction. Then can we say that he is asthmatic? No, right? So you need to prove that the airway is hyperresponsive in an individual to minimal loads of the substances, right? So airway hyperresponsiveness can be assessed by a test called as PD20, or if you want to call it as PC20, fine. PC stands for provocative challenge. Provocative challenge, or you can call PD20 as provocative dose 20. Provocative dose 20. Okay, so what is this provocative dose 20 or PC20? This is basically like you can use methacholine, or there are other substances which can be used. Most commonly used is methacholine. So it is the dose of methacholine that is required to reduce the patient's FEV1, right? We are talking about FEV1 again. So the dose of methacholine required to reduce patients FEV1 by 20%. That is what we call as provocative dose or provocative challenge 20, right? The smaller it is or lower it is, that means airway hyperresponsiveness is higher, right? Because that means less quantity of methacholine is sufficient to reduce patients FEV1 by 20%. Larger the number, right, then less severe is the airway hyperresponsiveness. Now, objectively speaking, right, you need to remember that if the methacholine requirement is less than 400 micrograms to reduce the FEV1 by 20%, that can be said to be abnormal. That then you can say that it is indicative of significant airway hyperreactivity, right? So this is one number I want you to remember. FEV1 reduction by 20%. If methacholine value is less than 400 micrograms, then it is suggestive of significant airway hyperreactivity. If it is more than 400, in a normal individual also at higher values, higher than 400, may be able to trigger a drop in FEV1. Clear? Okay. Now, the other point we need to know is the assessment of airway hyperinflammation because of the eosinophilic inflammation. Eosinophilic inflammation. Because see, we spoke about two types of bronchial asthma, and in type 2 bronchial asthma, there is eosinophils involved, right? Now, can we assess the eosinophilic inflammation of the airway? Yes, we can do that by looking at fractional exhalation of nitric oxide. So, nitric oxide is produced by the cells in response to eosinophilic inflammation, right? So, if fractional exhalation of nitric oxide is high in the exhaled air, that basically means that there is eosinophilic inflammation of the airway. Now, this has less role when it comes to diagnosis, but it has an important role when it comes to monitoring of asthma patients. So when you start an asthmatic on the medications, particularly, as I've already told you, eosinophilic inflammation means good response to steroids. So if you're started on steroids, like let me say you have started someone on moderate to high dose of steroids, moderate to high dose of inhaled corticosteroids, and at that dose, if there is eosinophilic inflammation, we would be expecting a reasonable improvement. But if you don't see, right, you've started them, and if you don't see in terms of symptomatic improvement, then you can look at the FeNO, right? If FeNO has not reduced, even despite being on moderate to high dose of inhaled corticosteroids, then you can raise the suspicion of patient's compliance with medication. Patient may not be taking the medications, or his the technique of device use may be faulty, right? So it can be the fractional exhalation of nitric oxide can be used for assessing compliance with inhaled corticosteroids. Okay. Now, when the fractional exhalation of nitric oxide is more than 20 parts per billion in a patient of severe asthma who is, as I've already told you, on moderate to high dose inhaled corticosteroid, that suggests a poor compliance. This is the exact statement from Harrison, and I want you to remember this. Okay. Apart from that, you should also remember that when the fractional exhalation is more than 35 in a treatment naive patient who has not received any inhaled corticosteroids or any treatment for bronchial asthma, it should be indicative of eosinophilic inflammation. So that way it can point towards the type 2 inflammatory asthma, right? So you have a patient who presented with asthma, is not received any medication. You check his FeNO, and if FeNO is more than 35, then you can almost be certain that you're dealing with a type 2 inflammatory asthma, and this patient might do well with inhaled corticosteroids. If it is a severe case at presentation, he might even do well with the oral corticosteroids, right? And if at all this patient is non-responsive to these medications, he might be benefited, because I'm talking about eosinophilic inflammation here. So such patients might be benefited with your IL-5 drugs, right? Like your benralizumab or reslizumab. These patients may be benefited with those drugs. Clear? Now, before we move on to discuss the management of asthma in the next section, there's one more MCQ-based area that you need to be aware about: the role of flow volume loops in diagnosis of bronchial asthma. The role is limited per se, right? We generally don't do a flow volume loop for diagnosis of bronchial asthma. All you need is a good history, and then after that, just do the PFT. Look at FEV1 and FEV1 by FVC ratio. If you are in doubt, also demonstrate the bronchodilator reversibility, and you're done. Your diagnosis is at your disposal. For management decisions, maybe you need to look at the IgE levels. You need to look at the eosinophil count, so that you can have a little tailor-made approach. And in most mild to moderate cases, probably you don't even need to look at the eosinophil levels or IgE levels, because the approach for GINA basically looks at patient symptom severity, and then according to that we come out with the medication choice, right? But examiners might ask you MCQs based on the flow volume loops. So what kind of flow volume loop you would be expecting in an asthmatic patient? Obviously, you will be expecting to see a intrathoracic, or in other words, an obstructive lung disease kind of a flow volume loop, right? Now, what is flow volume loop? In flow volume loop, on your x-axis, right, we are basically plotting the volume of air that is flowing in the lungs, right? Volume of air that is now accumulating in the lungs. And in your y-axis, basically, we will be plotting the flow rate, right? So volume is plotted on the x-axis, and on the y-axis the flow rate, right? Like flow rate is usually expressed in terms of liter per second, right? Liter per second. And on your x-axis it is the volume, which can be expressed in terms of liter. So let me start with a normal individual, right? If I have to plot the flow volume loop for a normal individual, what will be the starting point? Okay, let me complete one cycle of respiration. I have completed a full inspiration and I have expired all the air, and now I'm starting to document the next cycle. At the end of expiration, what is the situation of the lungs? Will there be any air, or it is absolutely devoid of air? It's definitely not devoid of air, right? So there is some amount of air present in the lungs, right? So the starting point is usually the residual volume. So the volume doesn't start with zero, right? So the flow may be zero, right? So this I can say that the flow rate starts with zero, and then it increases with in terms of liter, right? I can plot it like that, right? So flow starts with zero. At the end of expiration, the inspiratory flow is about to begin, so the flow rate right now is 0 per second. But inside the lung, there is some amount of volume of air already present, right? That represents your residual volume. So when I have to plot for the flow rate, I am plotting it on 0, and for the beginning of the inspiration, there is some amount of air present. So let me label here is our 0, right? But there is residual volume present. So we will start with the residual volume, and then once you start taking inspiration, right, the air is flowing into your lung. Now, for the sake of simplicity, this represents your expiration, right, and this represents your inspiration. So basically we are looking at, like, you have a device externally, and when you are expiring, the air is coming into the device, so that is represented on the positive side. And when you are inspiring, the air is sucked from the device, so that way it is on the negative side, right? Okay, so when you start inspiration, you're sucking the air from the device, so that means the volume is moving in a negative direction from the device, so that's why we are plotting it negative. So you started with some volume, right? You started with the residual volume. You start inspiration, right? And somewhere in the middle of the inspiration, the flow rate peaks, right? So this is the peak flow rate, and then the inspiration starts completing, right? So all it started with the development of negative intrathoracic pressure. So air started flowing into the airway and then into the lungs. But as the lungs started filling with air, lungs started expanding, the negative intrathoracic pressure is now decreasing. Eventually, the negative intrathoracic pressure that triggered the inspiration is now coming to an end, so inspiration ends. right? So at the end of inspiration, voluntary inspiration, you have achieved a tidal lung capacity, right? So here, when you inspired, you achieved a forced vital capacity, right? You took a deep breath, so you achieved a forced vital capacity. Now, at this point of time, from the residual volume, you have added a large quantity of air during inspiration. So we created this loop during inhalation. Now, at the end of inspiration, the flow will stop, right? The flow will stop. So the flow rate comes back to zero. So we started at the flow rate zero and we came back at the flow rate zero. We started at this point, we ended up at this point, right? Okay. Now you start exhalation. Normally, what happens is when you start exhalation, now exhalation is the exhalation of air into the device, so that is counted as positive. So that is why we will be seeing your expiration on the positive side of your y-axis, right? So once you start expiring, your the airway pressure starts going up, the flow rate starts going up, and it peaks, right? So expiration also has a peak. So at the peak, this is exactly what we call as peak expiratory flow rate, right? So it peaks, and after that, during the peak, probably the maximum amount of air is also exhaled out. After that, the expiratory flow starts dropping down, the rate starts dropping down till the expiration comes to halt or cessation, right? So at the end of that, it comes back to the baseline, that is zero. So flow rate during inspiration started with zero and reached back to zero. It started with zero in case of expiration and reached back to zero. But the volume, because there is residual volume, it started with the residual volume and then completed the forced vital capacity during inspiration, and whatever you had inhaled was exhaled during expiration. Now let us look at what happens in case of bronchial asthma. Like, as we are already familiar, right, in bronchial asthma, because the obstruction is mainly to the expiratory arm, right? Obstruction is mainly to the expiratory arm in comparison to the inspiratory arm. During expiration, the amount of air cleared from the lungs will be reduced. So this residual volume, right, this is what zero I am representing. The residual volume that was there in the lungs starts expanding. So this loop may get shifted towards the right, right? If this is right and this is left, this whole loop may be shifted towards the right. So that is the first change you will see. The flow volume loop in a case of asthma, right? The flow volume loop may be shifted to right. Why this shift to right is occurring? Because the residual volume is increased, right? So let me say, like, I'm representing 0 here. Let me say 1, 2, 3, 4, 5, 6, like this. So if the residual volume is increased, then the loop starting point may be here, right? So the loop starts here, and because of the obstruction, even the inspiration is to some extent affected. So this loop becomes little smaller, right? Little smaller. Clear? So it is starting at some other point, so it is getting shifted here, and its amplitude is reduced because of the reduced in the volume, right? And now from this point of time, expiratory arm is the one which is suffering more, right? So the peak expiratory flow rate will be reduced in an asthma, so the expiratory arm achieves a lower peak expiratory flow rate, and then the subsequent expiration is significantly affected, giving rise to this kind of an appearance that I'm drawing right now, right? So these are the changes that you would be expecting. Second thing you will see is the peak expiratory flow rate, which is reduced, right? So the flow volume loop is shifted to right, peak expiratory flow rate is reduced, and third, there is flattening of expiratory limb of the flow volume loop, right? Okay, so let me just show you some important examples. Okay, so this is one image that summarizes all the flow volume loop pattern that you would see, right? So this is a normal one, right? This is a normal one, started with an inspiration, right? And then this is the expiratory arm. This is our peak expiratory flow rate. Now, in case of a patient with the obstructive pattern, right, because the residual volume is increased, this whole curve may be shifted towards right. That's the first change you might see. The second thing is you will also note that the inspiratory flow is also reduced. Inspiratory flow is reduced, right? And then during expiration, the peak expiratory flow rate is reduced. This is the PFR that is reduced, and this arm, you can see this kind of flattening, right? Because as the expiration continues, it is it is because of the passive recoil, right? So initially there's a good recoil. After that, the airflow is significantly affected because there is nothing actively pushing the air out. So the flow rate significantly, steeply gets reduced. So you will get this shape in case of a obstructive lung disease. In case of COPD also similar. In case of bronchial asthma also similar picture. In case of a restrictive lung disease, generally what you can expect is the flow volume curve gets shifted to the left, I can say, right? If I have to say this as left, right? So the flow volume curve gets shifted to the left. Okay, that's what you will see in a case of restrictive lung disease. Peak expiratory flow rate will also be reduced in a restrictive lung disease, and during inspiration also flow rate may be slightly reduced in comparison to normal individuals, right? So you should be able to identify bronchial asthma flow volume loop, right? It is very easy to identify because of its peculiar shape, right? Okay, I hope I have made that clear. Now, having concluded that, we will wind up this session. So in this session we have addressed the part 1 where we were supposed to cover the clinical features, pathology, pathophysiology, and diagnostic approaches. In the subsequent session we will discuss about the management. Now, having understood the diagnosis, it is time for us to also address the variants of bronchial asthma. What are the variants? There are some important asthma variants. Number 1 I am talking about is what is called as cough variant asthma. Cough variant asthma. Okay, now one more important MCQ area is the flow volume loops. Now, if you ask me, do we use flow volume loops for the diagnosis of asthma? The answer is no, right? Because PFT serves the purpose. Like when you have taken a good history and you're suspecting asthma, all you need to do is do the PFT, look at FEV1 by FVC ratio. And if there is a possibility of COPD in the differential diagnosis, like an adult presenting with wheezes, right? In that case, maybe you also do bronchodilate reversibility, prove that it is a reversible bronchial obstruction, and at the end of it, you have your diagnosis, right? So we don't need the flow volume loop, but examiners do ask the questions related to flow volume loop. So we will understand a little bit about flow volume loop and what kind of flow volume loop you would see in a patient with bronchial asthma, right? Okay. So what is a flow volume loop? Flow volume loop is a graphic representation where we are plotting the volume of the lung against the flow rate during inspiration and expiration. So it will be a forced inspiration, voluntary forced inspiration, and a forced expiration that we will be looking at, not the normal tidal breathing. So you ask someone to take a deep breath, right? So when you take deep breath, let me start with the inspiration itself. So the expiration has ended and you're about to start an inspiration. You ask the person to take a deep breath. Now at this point of time, the beginning of inspiration, what is the flow rate in the airway? Expiration has ended, inspiration is supposed to start. What is going to be the flow rate? 0, right? So there is neither expiration happening nor inspiration happening, and like at this point of time the flow rate is 0. Now once you start inspiration, the flow rate starts increasing, right? So somewhere in the middle of the inspiration, flow rate through the airway is at its peak, and then it starts coming down. All this begins because of the development of negative intrathoracic pressure. Diaphragm descends down, the chest wall expands out, so there is a negative intrathoracic pressure, and that stretches the lungs out, and there is kind of vacuum created inside the lungs or negative pressure created inside the lungs, and the air flows into the lungs, right? So this airflow, the rate is what we are looking at, and the volume that is building up inside the lungs, right? So in x-axis we are basically plotting the volume, and in y-axis we are plotting the flow rate. Flow rate is expressed usually in terms of liters per second, and volume you can express in terms of liters, right? Here it is volume. Now at the end of expiration in a normal individual, right, what is going to be, like I have already told you, the rate will be 0, flow rate will be 0, right? It starts from 0. But what about the volume? Will that be 0 or will that be a positive number? Obviously, when at the end of expiration, the lungs are not completely emptied of air, right? So there is still residual volume present, right? So your starting point for volume is a residual volume, right? Your starting point for volume is residual volume. So if the volume is plotted at 0 here, and then we are plotting it in this direction in terms of volume, right? Then your 0 is here, right? Now this accounts for your residual volume. So your lung volume begins not at 0 but at residual volume, but your flow rate begins at 0. Now flow rates you can express along the y-axis in positives and negative, because we need to have a referencing, right? So let us say that you are doing this flow volume loop using a device. So device, if the air is coming in the direction of device, it will be counted as positive. If it is moving away from the direction of device, it will be counted as negative. So when you are exhaling, it is moving into the device, so it will be on the positive side. So this represents our expiration or expiratory arm, right? On the other hand, when the air is moving away from the device you are taking the air in, right? That represent, like, that will lead to negative marking, so that represents inspiration. So what you see on the bottom of the image is inspiration, what you see on top half of the image is expiration, right? So let me start with the inspiration with the residual volume already in lungs. Flow rate is 0 at this point of time, right? The volume is something which is more than your residual volume. You start taking an inspiration, so the flow rates keep increasing. It peaks somewhere in the middle of the inspiration. During this time, right, the volume in the lung is also increased, so the negative interthoracic pressure is dying out, so your flow rate starts coming down, and eventually at the end of inspiration flow rate reaches 0. So what started with the 0 flow rate is back to 0 flow rate, but during this period inspiration is completed, so the lung volume increased, right? So at the end of this, what we have achieved is we have got the forced vital capacity. Because it was a deep forced inspiration, we have got the forced vital capacity. Now it is time for the expiration to begin. So once the expiration starts, right, what happens to the flow rate? During the expiration, the lungs are passively recoiling, diaphragm is returning to its position. So this passive recoil will force the air out. And when the stretch is more, right? So to start with, the stretch is more, and that will start pushing this force out, right? So the recoil will be stronger when the stretch is more. But as it starts recoiling, the force of recoil starts coming down, right? So you have a peak flow rate which starts increasing initially, it peaks, and after that, once the stretch is limited, or the stretch which was more in the beginning, it has now started to collapse to some extent, the flow rate starts dropping down, right? So from the peak, the flow rate starts dropping down. So again, in case of expiration, flow rate started from 0. At the end of expiration, flow rates came to 0. During this period, right, we exhaled out the air that we had inhaled, right? Now when you look at this loop, you will see something at the peak of the expiratory arm. What is that? That is our peak expiratory flow rate, right? So your peak expiratory flow rate is achieved at the peak of this expiratory arm. Now let us see what happens in case of bronchial asthma. I think you're already familiar that in bronchial asthma, the peak expiratory flow will be reduced, right? Okay. Now, as I've already told you, when we talk about obstructive lung disease, obstruction is more to the expiration than to inspiration, but inspiration also suffers obstruction, right? So the inspiratory flow rate will be reduced. So you will not see this full length loop, you will see a smaller loop because the inspiratory flow rate, the maximal inspiratory flow rate will be reduced. Similarly, the peak expiratory flow rate will be reduced. So you will have a loop which is smaller than your regular loop. That's one change that you will see. The second change you will see in a patient who is having obstructive lung disease is because of the persistent or chronic or repeated obstruction to expiration, there will be some amount of air trapping, right? So this residual volume that we discussed will be increased or expanded, right? So the amount of air at the end of expiration inside the lung will be more. So because of that, this residual volume will be increased. So I can say that your loop probably starts from here, right? So the residual volume is expanded in a case of bronchial asthma. That's the first change you will see. Then the second change you will see is the peak inspiratory flow is reduced. So the inspiratory flow rate may be lower, right? So this loop becomes smaller. Now because the peak expiratory flow rate is also reduced, the expiratory limb becomes stunted. Okay. The second thing you need to note is because expiration is because of the passive recoil, right? When it is stretched initially more, somehow there is decent amount of expiration occurring. But as the lung starts collapsing back, that remaining air will not be emptied well, right? That's what I told you. The residual volume is increasing. So in after the peak expiratory flow rate is achieved, after that this expiratory limb starts becoming steeply flatter, right? Instead of having this normal inclination, it starts becoming steeply flatter. So this is the shape that our obstructive lung disease would appear, right? This is the shape that it would look like. So the moment you say such a flow loop, you can clearly think of obstructive lung disease, right? It could be asthma or COPD, or you can say the obstruction is inside the lungs or inside the airway, not the extrathoracic obstruction, right? Okay, so let me show you one more image that kind of gives you a little clarity about flow volume loops. So in this image, you can see the normal flow volume loop, right? This is your normal flow volume loop. In case of an obstructive lung disease, the peak expiratory flow rate is reduced and your peak inspiratory flow rate is reduced and the volumes are also reduced, right? And because there is a residual volume which is increased, this curve is getting shifted, right? Okay. In case of restrictive lung disease, the volumes are reduced, but there is no major obstruction to airflow, expiratory airflow. So you will not see this steep flattening of the expiratory limb. So you'll see that the expiratory limb is still relatively straight, right? So that's about the flow volume loop patterns. Now, having quickly covered that, it's time for us to talk about the bronchial asthma variants. One more important MCQ area per se, right? Okay. Now, the first bronchial asthma variant I'm talking about is called as cough variant asthma. Cough variant asthma. As I have already told you, cough variant asthma is a kind of asthma where the presenting complaint is usually cough, or predominant complaint is cough, not wheeze, right? Now, what you need to know from the MCQ perspective is cough variant asthma is typically more common in children. So most adults present with wheeze as the complaint. Children may be brought with the complaints of repeated attacks of cough. Now, what attention you need to pay is when some child is brought with repeated attacks of cough, right? Look for the history of diurnal variations. If the attacks are more in the night or early morning hours, when the ambient temperature is going down, right? So if that is triggering the asthma episodes, or again, we also know that early morning is where our lung functions are at its poor stage, right? So where asthma can be precipitated. That is one point you will see. Now, how do you diagnose these patients? The diagnosis is as usual PFT based only, right? So these patients who presented with episodic cough running for several weeks, when you do PFT, you will have all the asthma features, right? So in these patients, just like the conventional asthma, FEV1 will be reduced. Your FEV1 by FVC ratio will be less than 70% and bronchodilator reversibility will be positive, right? So this FEV1 that was reduced when you give bronchodilators, right, by 15 minutes into the bronchodilator administration, FEV1 should increase by more than or equal to 10%. All that typical asthma diagnostic criteria will be met here. Only difference is presenting complaint is not the wheeze, indeed it is cough, and wheeze may not be appreciated at the time of presentation. It may be there also when you auscultate, but the complaint that is brought out is usually in the form of cough. And MCQ point is it is more common in children, right? I'm talking about this because there was one MCQ which was having one statement which said that cough variant asthma is more common in adults, and for that question that was the right answer. That was a false statement, right? Okay. Now the second variant of asthma I'm talking about is what is called as exercise induced asthma. Exercise induced asthma. Okay, so exercise induced asthma is an entity where there is precipitous decrease in the lung functions and development of bronchoconstriction whenever someone is subjected to extreme exertion, as in case of athletes, right? Now, whether we should call it as a variant of asthma or not itself is a debatable factor, because in many of these patients, there may not be hypersensitization, or there may not be elevation in the IgE levels or eosinophil counts, or for that matter, even other inflammatory markers, right? So there are various other hypotheses explaining why this occurs. But at least from the sake of exams, let us look at what we need to know. Exercise-induced asthma is a condition where patients present with development of bronchoconstriction. I'm not using the word asthma here so that I'm technically safe. Development of bronchoconstriction, right, due to exercise. Now, why this occurs? This occurs because when we are doing exertion, right, we are hyperventilating. So exertion leads to hyperventilation, and whenever there is hyperventilation, there can be airway. Hyperventilation can lead to airway dryness, right? And as I've already discussed, airway dryness is a trigger for mast cell degranulation. Mast cell degranulation. And once the mast cell degranulation occurs, there is obviously precipitation, like there is histamine released, there is release of prostaglandins and other inflammatory mediators which cause an asthma attack or a bronchoconstriction attack to appear. Right? Now, one important point you need to know. Again, this is a very important MCQ point. The point is, in exercise-induced asthma, patients do not develop asthma symptoms when they are doing exercise. They develop the asthma symptoms usually several minutes after they have taken a break from exercise. The reason for that is when they are doing exertion or when they are into the exercise, there is adrenaline production, right? And we know that when we talk about asthma, we basically talk about sympathomimetics, or the bronchodilator is kind of equivalent to sympathomimetics, right? So we are giving stimulants of the beta adrenergic receptors to relieve the bronchoconstriction. That kind of job is done by the adrenaline surge. So when you are doing exertion, adrenaline is released and that acts as a defense against your asthma attack. But once you stop the exercise and you're taking rest, the adrenaline being a very short acting substance, right, its effect quickly wears off. But the mast cell degranulation has led to production of some of the cytokines which are having relative long action. And because of that, the beneficial effect of adrenaline wears off, and the inflammatory markers produced by the mast cells are still lingering on when you're taking rest, and that starts precipitation of the bronchoconstriction, right? So these patients develop bronchoconstriction usually 20 to 30 minutes after exercise is stopped. After exercise is stopped. So if there is an MCQ which had a statement, like there was an MCQ which had a statement, the statement was like the exercise induced asthma is because of hyperventilation. True statement. In exercise induced asthma, patient experience severe precipitous fall in lung functions during exercise. False statement, right? It cannot be true because the lung functions would fall once the bronchoconstriction sets in, and that happens after patient has caused the cessation of exertion, not during exertion, and I've already explained the mechanism behind that. Okay. Now the last variant we are talking about, the bronchial asthma, is what is called as occupational asthma. Now, why I'm talking separately about occupational asthma is occupational asthma, as we all know, is because of exposure to occupational allergens. Now, how can we suspect it? We can suspect if there is a typical history of having asthma episodes or worst asthma days on working days, and on holidays or weekends, if patient feels better, that should be a pointer to think that patient may be having occupational asthma, because that means on working place he is getting exposed to those allergens, and when he's back home there is no longer exposure of allergen and he feels better, right? So if asthma that is worse on working days and better on non-working days, you should think of occupational asthma. Working days and better on non-working days, you should think of occupational asthma. Clear? Okay. Now this is the point that makes you suspect occupational asthma. Right? But why should we differentiate occupational asthma from any other case of asthma? The reason is, if detected within 6 months of onset, then asthma is generally reversible, because by this time the airway remodeling that we discussed about the smooth muscle hypertrophy, basement membrane thickening, collagen fibrils, goblet cell metaplasia, all of that would not have occurred within 6 months of the onset of asthma. Right? So if patient started this profession just 4 months back or 5 months back, and now he's having typical history of asthma that is worst on working days and it gets better when he is not working. Now this is a time for him to change the occupation. If he changes the occupation, then asthma is completely reversible, right? So if he is not having exposure anymore, he don't need to take regular medication, regular inhalers or long-term medication or maintenance medication is not required. But after 6 months, the airway remodeling would have set in, right? After 6 months, the airway remodeling would have set in, and after that, asthma is not reversible. Even if he changes the occupation, right? He will remain an asthmatic, and probably he might require maintenance medication. Exposure to other allergens or other triggers might precipitate asthma attacks, right? Remember this point now. 6 months is the number to remember. Airway remodeling occurs, and then asthma is not reversible. Like now, there is a point to address. If you are diagnosing occupational asthma after 6 months, then asthma is not reversible. So does that mean that we can allow the patient to continue the profession? Ideally speaking, no, because at his workplace he will still continue to have the trigger exposure, and because of that asthma severity will increase, and as the time progresses it will become more and more severe, right? So in both the cases, ideally we should recommend change of occupation, right? Change of occupation. There are various emotional as well as financial dimensions involved. So it is more or less, you can say, it is the rehabilitation from the disease perspective as well as rehabilitation from the financial perspective. But yeah, we should ideally recommend change of occupation whenever we are dealing with the case of occupational asthma. Okay, so with this we come to the end of the part 1 of the asthma module. So in this module we have addressed the clinical features, pathophysiology, diagnostic aspects and certain variants of asthma. In the second module we will discuss about the management of asthma according to GINA 2022 guidelines.